Good morning. Thank you for joining us today, Dr. Nemati.
Yeah, good
How's
morning.
San Diego? Are you in San Diego right now, or?
Yes, it's very foggy outside, which means it's going to be very hot
Oh,
by
we just got some
afternoon.
fresh snow, so
All right.
yeah, cool. Yeah, thank you for joining us today, and we're really looking forward to your talk.
Thank you very much for inviting me.
Yeah, okay. I guess, Dr. Nemati, could you share your screen?
Sure, yeah. Give me a second here. If I'm looking to the left and right, it's because I have 3 different screens on my desktop here. Let me see. All right.
Okay. Yeah, welcome everybody. So Dr. Nemati today is gonna talk about his research, and we're really looking forward to welcome everybody. Yes, thank you. How do I mute here?
All right. Good morning, everyone. I'm Shamim Nemati, Associate Professor of Biomedical Informatics at UC San Diego. I'm also the Director of Predictive Health Analytics at UC San Diego Health, which is our hospital here. Today, I'm going to talk about some of the work we have been doing for early prediction of sepsis, both algorithm development as well as implementation aspect of that. Okay, so with that, as I mentioned, I run an NIH-funded research group at UCSC. This allows me to work with a fantastic group of people and also allows me to get credit for everybody's work. You're going to hear some of the works of my students here. I also co-founded a company called Helsigio, which is a UCSC startup, which also allows me to get credit for some of the work that they are doing. All right, with that, a little bit about my background. I did my undergrad at the University of Oklahoma around year 2000. Some of you may not know this, but Norman, Oklahoma, that's where the National Weather Center is. So I spent my undergrad chasing after tornadoes and using techniques from electrical engineering, from statistics, machine learning to detect tornadoes in radar images and then tracking their movement. I will get back into that because I believe there are certain lessons from chasing tornadoes that is relevant also to tracking patients' trajectories. I moved to Boston in 2007. I was a PhD student at MIT. So my heart goes for you guys, for all the snow that you're experiencing. I was at Boston for about 8 years. This is a picture from my street right next to Harvard Square. And then in 2015, I moved to Atlanta, Georgia. I was a faculty at Emory University for about 4 years before moving to UC San Diego in 2019. When I arrived at UCSD, I was very lucky that 2 of my mentors, they introduced me to Dr. Gabe Wardy, who is the chair of our sepsis committee. And he really made me start thinking about sepsis from a perspective of hospital and hospital administrators to see what are the things that they care about. I was working on sepsis at this point for about 4 years already, but it was mostly from an academic point of view. So for those of you who are not familiar with sepsis, sepsis is a form of dysregulated host response to infection, which results in blood clots and leaky vessels that, if goes untreated, can result in end organ damage. Patients who experience septic shock, they have mortality upward of 40%. It turns out 1 out of 3 patients who die in hospitals, they have sepsis, and annually 1.7 million individuals in US, they are diagnosed with sepsis. The mortality rate of sepsis is about, as I mentioned, 10 to 15%, but if it goes untreated, it can be very high. The good news is we know if you can treat sepsis early, put patients on antibiotics, you can save lives. There has been a number of studies that shows anywhere between 5 to 7% increase in sepsis mortality with every hour of delay in treatments. None of these studies have been randomized. They were mostly observational, but there has been sort of a consistent reporting, at least using observational data, that early treatment matters. So this is one of the first works when I was at Emory University in 2018. We published this work in Critical Care Medicine. What you are seeing here is a trajectory of a patient over a period of 48 or 72 hours. Sometimes around the end of this timeline, you see that clinicians, they ordered a couple of antibiotics and ordered 3 different cultures. One of them came back as positive. The green line that you see here is what we call SOFA, or Sequential Organ Failure Assessment Score, which is a score used to assess organ failure. So according to the consensus criteria for sepsis, when there is clinical suspicion, as denoted by ordering of antibiotics and cultures, and then there is also a 2-point increase in organ failure, indicating that patient is experiencing organ injury. Together, they satisfy the so-called sepsis 3 criteria for sepsis. And the red line over here is essentially showing when the patient fulfilled that criteria. The algorithm that we developed at the time, it was called ACE, or AI Sepsis Expert, went above the threshold several hours in advance. And if you look at the vital signs over here, you see around the same time, there's an increase in heart rate, there's a decrease in blood pressure. And what was interesting about this particular algorithm was that we said it's interpretable. At the time, most of the machine learning algorithms were considered black box. So we showed that not only we can make predictions, but also we can show what are the top reasons the algorithm is making those predictions. For instance, earlier on in the patient's timeline, it was temperature, heart rate. This patient had surgery, had an open or contaminated wound. And by the time we get closer to the time of sepsis, we see certain markers of end organ damage, such as creatinine and lactate showing up. All right, so around the time this paper was published, I moved to UC San Diego, and we tried to implement and test this algorithm at UC San Diego, and it didn't generalize very well. And I will get into some of the underlying reasons, but we worked on another paper which really focused on these notions of generalizability and data quality. This one was published in Nature Digital Medicine in 2021. It's called Artificial Intelligence Sepsis Prediction Algorithm Learns to Say, I don't know, which the main idea was to pay extra attention to the conditions for use of the algorithm to make sure that the data that goes into the algorithms conforms to the requirements of the algorithm. And then in 2024, earlier this year, we published a paper in Nature Digital Medicine demonstrating improvement in patient-centered outcomes using this algorithm. And I will go into more details shortly. Once this paper was published, Politico wrote an article saying that AI has mountains of data to study. And there's a quotation from Dr. Atul Biyut that I really like. He basically says, to me, it's a tragedy now if we don't use all of this data to improve the practice of medicine. And this has been a huge challenge, really moving the needle forward and going from retrospective modeling to prospective implementation studies and improving actually patient-centered outcomes. So what are we talking about in terms of data? I'm sure all of you are familiar with all the different data types that we are collecting, from patient demographics, patient information, to diagnosis, related billing codes, interventions, imaging data, tons and tons of clinical notes, and then physiological data from bedside monitors, etc. So the value proposition is that using advanced AI models, we can integrate these diverse data types and make accurate predictions. there are different ways of thinking about the predictions of these models. One idea is that these models, they can improve situational awareness. So nurses, providers know how to prioritize patients. But you can take it to the next level and maybe think about AI being able to phenotype patients and personalize cares to say that, this patient group, they require not only higher level of care, but also maybe because this patient is experiencing congestive heart failure, you should not give too much of fluids to this patient. So that's the idea of personalization. And the notion of optimization of treatment protocols is something that is very dear to my heart. And we have been working at that domain, things like how do you dose heparin, which has a narrow therapeutic range? How do you dose immune suppressant drug like Tacro to help with patients post kidney injury or liver failure, figuring out how to dose those medications. So that's another area. Having said that, the limitations has been that, as one of my mentors calls it, is it really data or data? The data that gets collected is not really for high quality research and predictions. It's mostly for billing purposes. And so data can be noisy. In spite of that, you may argue that clinically, especially during the times of shift change, when a new physician comes in, they have to rely on very similar data in electronic health record to figure out what's going on with the patient and start their treatments. I would say that a bigger problem with big data is that it's not always timely data. We are in 2024, but medicine still is very reactive. We often wait for patients to decompensate, and that's when we order our labs. And that's a problem. If you are interested in early prediction, improving sort of situational awareness, you want to have access to timely data. And that's sort of a fundamental issue that we are dealing with. And I will talk about how we are planning to mitigate some of the related issues. And then, as you all are familiar, data can be very siloed. Your bedside monitoring data might not be talking to your EHR, and matching data can be quite difficult. But also, across different institutions, data is very siloed, and building multi-institutional models can be challenging. I know people from your team has been working quite a bit on things like transfer learning, et cetera, to address some of those issues. And then there is a lack of interoperability, especially when you go and try to prospectively implement these models. But there are tons and tons of advancement in this field, which is very promising. All right, so what happens if you don't pay attention to these factors? We just recruited Dr. Karandeep Singh to UC San Diego. He's our new Chief of AI Officer. We are very, very excited. He published a paper in 2021 showing that a commercially available sepsis algorithm basically performs much worse than advertised. So there are potentially a number of factors contributing to this. The data quality is one component of that. The implementation protocols, paying attention to the details of that are important. And then as I mentioned, there are differences in characteristics of patients across different populations. And so addressing all of these are important for building generalizable models. So when you talk to clinicians and you ask them about what they think about this type of systems, they often say that this type of systems, they have high false alarm rates. And then sometimes they say, is it safe for the patient to rely on this type of systems due to issues of false alarm and automation bias, which is when end users, they become too dependent on a system. And if the system fails, then that could put the patient at potential risk. But this notion of liability comes up. The other one is they say, tell me something I do not know. The idea that there is, and there was a paper out of our colleagues at Harvard DBMI talking about that a lot of AI systems are essentially looking over clinicians' shoulders. What they mean is that when AI systems, they see abnormal data, there is a reason that that data was collected. Let me actually demonstrate that in an example right here. So here's a patient, around 8 a.m., there was some signs of inflammatory response. A slightly elevated temperature, respiratory rate was slightly elevated, similarly the heart rate. And for some reason, this was a floor patient. This goes, unnoticed. And then there's a period of time that there is no recording is going on. And so if your AI algorithm are making your predictions and there is no data, essentially you're going to sample and hold. And so the prediction is going to stay pretty constant. So around 2 o'clock in the afternoon, somebody noticed that this patient was experiencing hypotension. And that's when they ordered a bunch of labs. And as soon as the lab results came back, the AI algorithm jumped from 7 to 81, saying that this patient is likely septic. It took the team another hour to call code sepsis. This patient by this time was hypotensive. They were trying to figure out why many of these patients, they are complex. It's not really clear what the underlying cause is. By the time they decided it was sepsis and they put the patient on Zosyn, it was already 5 o'clock. They switched to vancomycin an hour later. And then this patient now is in a state of shock. And so this patient turns out didn't survive this hospitalization. So this is a very clear example of data being delayed. And the AI is really essentially looking over a clinician's shoulder because without the right measurements, it wouldn't have been able to make this prediction. Having said that, even given that, we could have started antibiotics a few hours earlier if the AI system was available at the time for the clinicians. So you could think about it as AI would have been able to reduce some of the diagnostic uncertainty that exists. All right, so, and the last item is clinicians, they say, what should I do? They typically say, we are doing everything possible for our patients. And that's where thinking about downstreams to predictions about optimizing treatment protocols, et cetera, is super important because that gets you closer to actionability. All right, so I mentioned this paper that we published. This is really was focused on a couple of things. One of them was reducing false alarms. The other one was improving generalizability of this type of models. The basic idea is once you train a model on a given hospital, I call that hospital A, the typical approach is you go to another hospital and you push the data through your model, in this case, a neural network, and you make a prediction. That's sort of the traditional approach. The approach that we proposed was based on this idea of conformal prediction. We collected samples of septic and non-septic patients that the algorithm during the training phase performed exceptionally well. And we constructed something is called the trust set. The idea is that when you go to hospital B, you push the data through your neural network, you come up with something called a condensed representation of your input data. Then you essentially perform k-nearest neighbor search to see, are there examples from my trust set close by? So the idea is to assess whether you have seen examples of that similar nature in the past or not. If the answer is no, the algorithm actually says, I don't know about this case. I have never seen a patient similar to this patient, and I'm going to tag this patient as indeterminate. There are different reasons for this rejection. One of the reasons could be that the patient was never seen before, is an outlier patient, is out of domain patient. It could be also that the data quality is not correct, is not high enough. Regardless, the algorithm says this is indeterminate cases. For the remaining patients, the algorithm makes the predictions for sepsis. And what we showed that was that using this approach, you can reduce false alarms by about like 70, 75%. You could also demonstrate much better generalizability across different patient populations. So we had data from intensive care units, emergency departments across 2 hospitals, and we showed you can have much better generalizability using this approach. But also within the same healthcare systems, there's this notion of temporal shift or drift in data. And one of the objectives of conformal prediction is to temporally monitor the data streams. And what we have in place is essentially a dashboard that keeps track of the rejection rates of the model. And if the rejection rates increase over time, it's probably a good indication that something in the input data changed. And so maybe the algorithm needs to be updated, or the input data needs to be sort of audited to make sure it conforms to the algorithm. So that was the idea behind this paper. We built a very simple Tableau-based user interface that you have the patient information, their demographics, the top causes for why the algorithm thinks this patient is septic, and then we essentially put the score and a question mark saying that the algorithm is not really sure about this case. So that was sort of the initial design. And we thought about how to go about implementing a system like this. So as you guys all know, there are many papers published about predictive analytics. Our team also had a couple of papers. These are all retrospective. And the challenge really has been to push it forward into clinical practice. What you see here are the number of publications related to like AI in medicine. And what is really hard to see here in blue bars are the number of prospective studies or clinical trials in this domain. All right, so how do you go from bits to bedside? How do you build the sort of the infrastructure of deploying this type of systems? There was a paper just published in Nature Medicine in January saying that integration of AI in healthcare requires an interoperable digital data ecosystem. So this is exactly what we have been working on since 2002. We built what I call a real-time analytic pipeline that includes a number of components. As you guys may know, the way device information gets communicated to electronic health record is through this standard called HL7. More recently, there are standards of interoperability called FHIR, F-H-I-R, which allows for certain level of harmonization of this data. FHIR also provides a set of standardized APIs for data access. So we, within our HIPAA compliant AWS environment, we essentially build a pipeline that listens for incoming HL7 messages in the form of what we call the ADT messages, which stands for admit, discharge, and transfer. Essentially, anytime anybody steps into our hospitals, we get their data in real time, and we know that they are present within our emergency department or hospital wards. Once we know that they are present, we use their MRNs and encounter numbers to call the FHIR server for their most up-to-date data. We do this in an hourly basis. We perform feature extraction, and then we pass it to this composer deep learning model that I mentioned earlier to make predictions. Once the predictions are done, we send the information back into our electronic health record, which is EPIC, using an interface that is commonly used by manufacturers of bedside devices. This is called the incoming device data HL7 messaging protocol. And this allows us to push the information back into EHR and have it land in flow sheets. Once the data is available in flow sheets, then we are able to build best practice advisories for our clinical team. So we initially started with deployment of Composer, but since then, using efficiencies of cloud, we are able to scale this up to multiple types of algorithms. I will not have time to talk about all of this, but we have papers published on respiratory failure, in general deterioration, prediction of shock, etc. And the pipeline allows us to deploy all of these models simultaneously, and they all get written back into electronic health record. All right. But that's not the end of the story. Any clinician who is maybe listening here, they would tell you that there are a lot more goes into integration of these type of models into clinical workflow. The way I like to think about this is in terms of the sort of different layers. The first layer is what I call the IT infrastructure. This is where data gets recorded and ingested and harmonized. The next layer is AI, and there has been a lot of focus on the AI layer, but it doesn't stop there. The next layer, what I call policy interface. Policy for me is really about getting the risk scores, getting the recommendations of AI, and figuring out how to meaningfully convert it to clinically actionable interfaces or patient lists or recommendations for clinicians. When you go about putting this policy interface, you have to think about workflow constraints. What are your quality objectives? What are the financial and legal constraints? I just give you some examples. You may decide that certain units within the hospital are not really receptive to deployment of AI systems. So you want to exclude those as a part of this, your policy. You may want to decide patients who are already on antibiotics or receiving treatments, you don't want to send any alerts to physicians about those because they're going to get annoyed most likely. So that's another example of sort of policy. There are other policy, sometimes there are financial constraints. Maybe there are certain departments within the hospital that are losing a lot of money because of sepsis. And so you want to make your algorithm extra sensitive within those areas. So the policy interface allows you to put all of those in place. But the next level is what I call the behavioral layer. This is human beings, providers, clinicians, caregivers interfacing with the AI system and with the clinical decision support tool. I often mention this to my students that you may have an AI system that is highly, highly accurate. But if the end users, they keep snoozing the AI system, guess what is going to be the positive predictive value of that model? Close to zero, right? So this behavioral layer, which is really about trust of the system, is about how providers interact with the systems, is super important. And then currently, data generation is really triggered by the providers. So I mentioned that if they don't realize or if they don't recognize that patient is not doing well, they are not going to order the labs that then get ingested to the AI system. So one of the things, if I have time, I'd like to mention is we have currently a fundamental limitations with existing EHR data, because as I mentioned, the data is often delayed. And my team and some other groups, we are really trying to push to see if there are ways for AI systems to get involved in triggering order sets to get data in a more timely fashion. All right, so here we are. This is a picture from early 2021. We built a Tableau dashboard and we engaged in what is called silent mode. We weren't quite comfortable or ready to deploy our AI system at this point. We wanted to really get a group of experts in a room and ask them about the performance of our system. At this time, the algorithm was running in the background, but none of our providers had access to this model. So we brought together a diverse group of potential end users, including critical care physicians, hospitalists, RRT nurses, ED physicians, and medical students. And for a period of about 6 months, we performed what I call, again, real-time chart review. The reason it's so important to do this sort of chart review in real time rather than retrospectively is because any physician can tell you that in real time, when you're dealing with patients, diagnostic uncertainty is very high. So we wanted to know, at the time that diagnostic uncertainty is very high, what our clinical team, our providers are thinking about these patients that our algorithm is flagging as being high risk for sepsis. And this process was really, really eye-opening for all of us. The clinical team, there were several instances where they said, definitely this is not a septic patient. And 5 hours later or 6 hours later, we got a text saying that that patient that we reviewed was in fact septic, and the treatment was delayed. Similarly, the data science team, they learned tons and tons about all the different complications, what we call sort of the sepsis mimics that complicates the task of predicting sepsis. These are patients, let me go to the next slide. These are patients such as cirrhotic patients, patients with GI hemorrhage, patients who are experiencing alcohol withdrawal. That if you think from a perspective of inflammatory response, they're all having that inflammatory response, but there is no underlying infection potentially. So I'd like to highlight three categories of these patients: post-operative patients who are experiencing inflammation, and that inflammation basically translates into increase in heart rate, increase in white blood count, etc. Some of these patients, they end up having drugs such as a steroid that also elevates their inflammatory biomarkers, and they might look like septic patients. Then we have the trauma patients. And finally, there's this category of cirrhotic patients, and I also mentioned GI bleeds. So we had to really spend a good 6 months building rules into the system to address all of these scenarios. So the current AI system that is actually running at UC San Diego is a hybrid system. You have the AI making the predictions, but we also have what I call a suppression logic on the top of that to address all of these cases. Because just purely based on physiological clinical data that we have is often difficult to distinguish between sepsis and these other cases. So as a result of this this approach, we managed to get the positive predictive value of this composer model to about 26%. The latest iteration is now closer to 30%. So roughly 1 out of 3 alerts that we trigger, they are true alerts. It doesn't mean that the other 2 out of 3 are necessarily false alarms. When we look into those patients, essentially we observe the following categories. There are patients who have bacteremia or some sort of bacterial infection. They're just not septic. That's one category. I would say that's another 30%. And then you have patients who are very sick and require some sort of attention. And then you have some of the cases, such as I mentioned, like alcohol withdrawal patients, etc. In terms of actionability, I would say that probably over 60–70% of cases are in fact actionable because the patients would benefit from some sort of antibiotics. In terms of timeliness, we also, the way we define the time T0 is essentially based on the minimum of time of ordering of antibiotics or cultures. And we showed that the algorithm basically fires about on median 3.2 hours ahead of time. So moving forward, after about 6 months of a silent mode trial and building a lot of rules into the system, we got the courage to deploy this prospectively around December of 2022. At this point, we had a user interface within our Epic system. This is what is called a best practice advisory. It says this patient at risk for developing sepsis in the following 4 to 6 hours. We have an area where we list the top reasons why the system is thinking the patient is septic. We incorporated something that is sort of educational about the progression of patients from SEERS to sepsis to severe sepsis to septic shock, and what we call the SEP1 bundle, which basically says within 3 hours of severe sepsis, you need to put patients on antibiotics or their cultures or the lactates, and then in the following 3 hours, If the patient is experiencing hypotension, you need to order vasopressor, etc. The reason we included this in our nurse-facing best practice advisory pop-up is because we have a lot of traveling nurses here in San Diego. People come from all around the world to be close to the beach. And so anytime we have a new batch of nurses, it's super important to provide them with education. And some of that education happens in a more formal way, but we felt it was necessary to also include this because sometimes they just don't remember the criteria for sepsis. So we deployed this. We did a 5-6 months pilot study, and the result of that was just published in Nature Digital Medicine, demonstrating a 17% relative reduction in hospital mortality, which was accompanied by about 10% relative increase in sepsis bundle compliance. The more we try to look into the mechanism behind this, the more we realize it's probably due to really more timely administration of antibiotics. So if you look at this PPA here, it has certain options for the nurses. One of the options is to not notify the MD immediately. They could also say that we already know this patient is septic. They also have an option to just exit it and not acknowledge it. So we keep track of the reasons for exiting the system and or the way they interacted with the system. And we noticed the following categories, essentially. Over 50% of the time, the nurses, they said they will notify the MD immediately. There was about 5% that they said the sepsis workup is already in progress. Here are essentially our false positives. Nurses, they said there's no infection suspected. It's probably a mixture of false positives and some cases that later on they figure out the patient is septic. And then there was really only a very small portion, about 5%, that they exited those cases. So what we did next was to build a regression model and adjust for several confounders and try to see if there was any correlation between nurses saying that they will notify MDs immediately and timeliness of antibiotics. And we observed a strong signal there that whenever the nurses, they said they will notify MDs immediately, there was a reduction in time to antibiotics in this patient group. Following that, we performed a survey of our providers. This is something that is still under review, but we try to look at what are the factors that contributes to satisfaction or compliance with this type of alerts. And it turns out one of the strongest signals was related to the years of experience that the provider has. Providers with 0 to 5 years of experience, they were a lot more likely to accept the system and find it useful. Even though over 80% of providers, they said that either it was useful or at least it wasn't harmful, for providers with more years of experience, they were more likely to be neutral about the usefulness of the system. So we are continuing to improve this system and trying to figure out what are the reasons for sort of cases where compliance is low, etc. I really like this table that showed up in Nature Digital Medicine. This is an editorial by the editor-in-chief of Nature Digital Medicine and colleagues, looking at our implementation of this sepsis algorithm, and they really point out it takes a lot more than just AI to implement this type of systems. So they talk about the infrastructure needed, the type of user interface that you need to put in place, how do you gain the trust of end users, how do you educate them, how do you ensure that they stay engaged with this type of systems, and then thinking deeply about clinical context, what is actionable, after you have an alert. In the case of sepsis, antibiotics, fluid resuscitation, we already have a bundle in place, but it's not always clear in the case of other types of prediction what is really actionable. And then once you deploy these systems, that's not the end of the story. You need to monitor this type of systems over time. Earlier on, I mentioned that we monitor the rejection rate from the conformal prediction over time. And if the rejection rate increase, and we use it as a signal that the algorithm needs to go through what we call algorithm change protocol so that we can update it. So we built actually a quality dashboard that keeps track of the performance of the model over time. We can look at the performance across different care units. We can look at the performance across different patient demographics. Here we have that. And also using some of the utilities available within the cloud. In the case of Amazon Cloud, they have something called CloudWatch. We have built monitoring tools that every single component of our pipeline is constantly monitored. And if something goes down, let's say we are not able to get response back from the fire server, after 15 minutes, my team members, they get a pager. There's a service called Pager Duty. Anyways, we get pagers, and my engineers, they have to go in, look into it to see what's going on. If they can resolve the issue within an hour, that's great. If not, we notify our frontline nurses that the system is down because of this notion of automation bias. Again, the idea is that over time, the users might become too dependent on this type of systems, and they may have suspicion of sepsis. They might wait for the system to fire before they proceed to, let's say, informing the physician. So anyway, so there's a whole lot of that goes into post-implementation monitoring of the infrastructure, the algorithm itself, and having the end users in the loop as you track the performance of the model and various types of IT implementation related challenges. All right, so with that, I would like to use the remaining 10-15 minutes talk about some of the work that my team is working on currently as we move forward. The first one is this area of active sensing, which we really think it might be a solution to the issue that a lot of the data collected in EHRs is currently delayed. We are looking into wearables, biomarkers, and like many other groups, generative AI. Let's go back to this example, which actually there was no data available for AI to make the prediction. The idea is that we are really interested in early prediction, but in practice, we are getting delayed prediction because our data is delayed. And then by the time we get to the sort of intermediate diagnosis, it's fairly late. So what we really want to do is to come up with ways of moving that prediction earlier in time. By the way, the circle here is supposed to denote the amount of uncertainty that exists for the prediction. So this is really the idea here. So going back to this figure I showed earlier is showing the progression of patients from SIRS to sepsis to septic shock and the criteria that clinicians at the bedside they use to diagnose sepsis. And I'm showing this, but this is highly simplified because the clinicians in their head, they have to think about every single one of these biomarkers and think about what else can explain that before they make a diagnosis for sepsis. But based on this construct, we came up with a design that we are currently testing at UC San Diego. It looks a little bit complicated, but really the idea is we check for every patient for the SIRS criteria. And if the patient doesn't fulfill the criteria, we ask the question, is it because there is missing data? If there is missing data, then we go ahead and trigger a nursing order set that requires the nurse to get temperature, heart rate, mean arterial pressure in the patient. And if the patient now, after getting the information, meets the SIRS criteria, we look at organ failure criteria for sepsis. And again, if the patient is not meeting that criteria, we ask the question, is it because of missing data? If the answer is yes, it's due to missing data, we trigger an order set for some of the labs. And then if the patient at this point fulfills the organ failure criteria, we have an algorithm for assessing infection, or we prompt the nurse for, does your patient have infection? And if that's the case, then we put all of this together and present it to the provider as, potential case of sepsis. So here are examples of some of the, pop-ups. This is for collection of vitals. This is for collection of, additional labs. And you may ask the question, does this cause extra burden on the providers? Obviously, there is no free lunch. So we did some preliminary analysis in silent mode, seeing like how often this order sets, they get triggered. It turns out in the ED, in a room with 20 patients over a period of like 24 hours, gets triggered only once. And in the wards, again, the triggering frequency for the nursing assessment and order sets is pretty small. Having said that, there are other challenges. It's not just about the extra work of going and getting this additional information. Somebody is paying for these labs. If the patient is a Medicare patient, is the Center for Medicare and Medicaid is paying for these labs, right? So now there are issues related to if it is AI generated, who is going to pay for it? If you look at the guidelines from Center for Medicare and Medicaid, they basically say it has to be necessary, a lab, a diagnostic test needs to be necessary and reasonable. And the only people who are licensed to decide that are clinicians. So this idea that maybe AI systems can order certain labs is sort of, there are legal and regulatory constraints around that. So we are trying to work through some of those. But another way to go around this is to utilize different technologies to try to gather information. So you could think about, instead of triggering a nurse to go and do the nursing assessment, you could utilize wearable technology to gather some of the vital signs. Some of these are not really FDA cleared, versus there are other ones that are FDA cleared and can be used for gathering some of the vitals. Similarly, when it comes to some of the labs, if you want to have more timely, let's say, lactate, there are now new technologies emerging, such as these microneedle sensors that can provide you with minute-by-minute lactate measurements. And this is some work that our colleagues at the bioengineering department at UCSD are working on. And then when it comes to assessment of infection, we are starting to see some really good solutions. This is a biomarker from our colleagues at Informatics that provides a 1-hour turnaround time for differentiating viral versus bacterial infection. And really the idea is that if you can get this sort of information, it's going to make it a lot more actionable. I really like this figure. On the x-axis, you have things like likelihood of bacterial infection. And the y-axis, you have severity of illness. And it's basically saying that if the likelihood of bacterial infection is low, severity of illness is low, maybe you should wait and gather more information to have higher level of diagnostic certainty, versus if the patient is pretty sick, maybe you should, within 3 hours, you have to put the patient on antibiotics. If the patient is very sick and the likelihood of bacterial infection is also very high, you should immediately proceed to put the patient on antibiotics. So I think this type of AI systems that can trigger biomarkers are going to be quite powerful in terms of their actionability for somewhat personalizing some of these treatments. All right, I'm going to leave you with a few thoughts. One of them, in around 2012, I came across this quote by the Institute of Medicine saying that achieving higher quality care at lower costs will require fundamental commitments to the incentives, culture, and leadership that fosters continuous learning, as the lessons from research and each care experience are systematically captured, assessed, and translated into reliable care. I was drawn to this, this idea that every care experience can be ingested by AI systems to improve the next round of care that is provided to the patients. This is quite interesting, and we are starting to see some examples of that. But one thing I like to point out, and those of you who have a bit of a background in maybe electrical engineering or aerospace and familiar with control systems, you know that any type of system that has feedback loops built into it if there is delays in feedback, you are going to see a certain level of instability in the system, or at least the system is not going to be optimal. So one of the things we have been thinking about is that, how do you go about reducing these feedback delays? And sort of examples of these feedbacks are these quarterly quality metrics that are reportable to insurers, et cetera. So one of the things we are working on is we said, we are getting already all of this data in real time from the patients using, FHIR protocols. We are creating risk scores, but maybe we should really think more deeper about also the quality metrics that hospitals they really care about, as well as the cost, metrics. Anybody who has spent time in hospitals, they know that incentives often are not aligned. So really, I think the challenge for AI practitioners is to work with quality teams in hospitals and also with the financial teams and try to align incentives across improving patient cares, improving the quality metrics, and also the financial metrics. So what we are doing, as one example, is with the SEP1 bundle, we said, why are we doing this with 4 months delay through very time-consuming chart reviews? Why can't we get data in real time and use things like generative AI to automate some of these quality metrics? In that way, we can provide feedback to our clinicians in a much, much faster and timelier fashion, so they can go in and educate if necessary, change processes if necessary. So that's one area we are working on. And then the other part is, with the financial and cost saving, there are a lot of opportunities here, and I'm not going to go through that. So right now we are looking into scaling up this technology. Is cloud-based, so it's easily scalable. It's using interoperability standards. So we are working right now with a few partners, try to implement the system in other places and externally validate the system. Sort of the hope is, we have about 350,000 cases of sepsis death in the United States. Even if we can save 17% of these patients, that's about 60,000 patients per year. And that's one of our goals. All right, so this is my last slide. I asked ChatGPT, if Leo Tolstoy was alive today, and he was a sort of a data scientist dealing with the EHR, what would he say? And here is the ChatGPT's response, say that data is a raw material of science. Science is a pursuit of truth, and data can reveal patterns and trends, etc. He says, but data is not enough. Data alone cannot tell us what is good or evil. And basically saying that we need something else. We need art. And here is my message for the clinicians here. We really hope that these type of systems can help to reduce their work, to reduce the burdens of EHR documentations, etc., so that they can get back to the art of medicine, spending more time with patients and do what they're really good at. All right, with that, here are some of my funding sources, and thank you very much for your attention.
Thank you, Dr. Nemati. Seems like we have some questions in Q&A.
All right, I'm actually not able to see the connection because I'm looking at, let me see, I might have to switch over to.
I guess I can read out the questions.
Okay, please.
Yeah, so the first question we have on Q&A is, are there any currently integrated predictive models using dynamic patient data?
All right, so what I guess the question is, what is dynamic patient data? The system that we have in place, it's making hourly predictions, and it's making use of trends and sort of higher order correlations in the data. We have also published on use of things like recurrent neural networks that makes use of those sort of dynamics in the patient. If that's what they mean by dynamic data, yes, we have some of that dynamics built into the current system.
Cool, thank you. The second question we have is there any experience with UCSD's partners at UCI and UCR sharing data through their linked Epic EHR system?
Yeah, that's an excellent question. We had a paper published last year with a sepsis phenotyping model. We used data from UC Irvine. They were very kind to share that data. We are currently in the process of implementing this system live at UC Irvine, which should be fairly straightforward because UC San Diego actually manages UC Irvine's Epic instance, even though in many ways they are separate. But we have, in principle, should be able to make that implementation. So right now we are going through sort of the legals and contracting to get that done. And there are conversations ongoing with other campuses to implement this. I can get into some of the challenges. I think in general, doing this type of work on the research side is much harder than doing it on the hospital operation side as a sort of quality improvement work. And I can get into details, but so we are exploring different options to expand this system to other UC campuses.
Thank you.
Dr. Nemati, this is Abel Co. Thank you for presenting. This is a fantastic presentation.
Looks like I might have lost you
okay.
guys. I'm not able to hear.
Yeah.
Hold on. All right. In the meantime, you want to try the Q&A?
Oh, do we have another Q? Okay. Oh, I guess we have another question from the Q&A. So the question is, I'm curious about your approach to validating and scaling. How are you finding partners? Are you looking to partner with complementary, non-competing, but synergistic AI solutions being developed by other scientists or clinician teams?
Yeah, I mean, that's a great question. I think like with sepsis right now, I think probably at least 70% of the health systems, they are developing their own sepsis algorithms. So as you talk to hospital C-suites, one thing that they always say is they are not looking for one-trick pony type of solutions. And the reason is that there is overhead associated with IT implementation. With the introduction of FHIR, some of that overhead has been reduced. Just to give you an idea, when we first started, we had to do a full HL7-based integration, and that was really a nightmare. With FHIR, that overhead is less, but still maintaining these type of systems is challenging, right? So that's why hospitals, they are looking for solutions that expand across multiple indications. So that's one area. The other one area is I have some colleagues who are more on the entrepreneurs. They talk about authentic demand. So figuring out what people really want and what the challenges are. It may not be actually early prediction of sepsis. It might be something else. So we are all passionate about saving lives, but bundling solutions in a way that we address immediate needs, plus some of these other more advanced life-saving technologies, that's really the way to move forward. But we are in general open with collaborations, either as research collaboration or as other types of relationships, whatever works. And honestly, I mentioned that I have a conflict. We started a company. We never went through the route of raising any funds because we are just having fun getting non-dilutive federal investments, and so very low pressure, and we are having fun testing these different ideas, etc. So that's where we are right now.
Dr. Nemati, hopefully you can hear me now. This is Abel Co. I just want to thank you for presenting today your work. It's amazing. I think congratulations on your success. And also, I really appreciate your holistic approach to addressing this complicated problem. I think you mentioned the importance of things like data infrastructure, policy, communication workflow. Those are all super important. One thing I wondered is, you've been in the space for a long time, and how much do you think the needle has been bent towards improving outcomes for sepsis? I mean, many people have put sepsis algorithms together. This has been maybe one of the more well-studied conditions, or at least tried to study conditions. You look at 10, 20 years worth of work. Where do you see this going? I mean, do you think that the needle is moving? Is it bending now, or if not, what's needed?
Yeah, I mean, that's a great question. I think sepsis has been the sort of great graveyard of entrepreneurial activities and industry investments, and with a lot of biologics, things haven't really moved forward much. UC San Diego currently has the lowest OE ratio for sepsis mortality. Our numbers, they have been really good over the past year, but we are still studying whether that initial improvement was a Hawthorne effect or is going to be sustainable. So far, so good. There is considerable amount of excitement among our nurses still about this type of systems. So we'll see if we can maintain the performance. What I'm really excited about is this next phase where we can make these type of systems more actionable. I mentioned integration with biomarkers. The current problem is the AI system is making predictions, but it's not clear what's the underlying cause, right? So incorporating more biomarkers that have much faster turnaround time. Some of the older biomarkers for, let's say, pathogen profiling, they had a turnaround time of a week. Now we are starting to see solutions that is down to an hour. So I'm really excited about combining this type of technologies together, but also with wearable technology, being able to track patients. We just recruited our 15 patients who were sent home with Fitbit, trying to see if we can use some of those signals to predict readmissions. So I'm personally very optimistic about the next 5 years for sepsis research.
That's great. Thank you, Dr. Nemati. And I think we're at time. That improvement's probably because of you, Dr. Nemati, likely. So hopefully that pans out for the year. I just want to thank everyone for coming in person or online. And we look forward to seeing you guys at the next AI Forum in about 2 weeks. So thanks so much. Thank you.